Hello, everybody. Welcome to our session on promoting pediatric lead screening in Oregon. Debra Cherry, MD, MS, has no conflicts to disclose here. Next slide, please. Audio and video is muted for all of you participants, all of you attendees. If you want to send a chat message, select chat. It's lower right. If it's not visible for you, click on the ellipses button, so 3 dots there, and you'll see chat and Q&A. Please use the Q&A to ask questions and we'll be able to answer. We'll be keeping an eye on the Q&A and chat for everything. Presentations and slides will be posted shortly on our website at the link there. If you'd like CE for this session, please complete the survey. I'll be popping the link into the chat in just a moment. We'll also be sending that by email to you all once the session is over. Debra Cherry, MD, MS, is a board-certified occupational medicine physician at Harborview Medical Center, director of the UW Medicine of Occupational and Environmental Medicine Residency, and a UW Associate Professor of General Internal Medicine and an Adjunct Associate Professor of Environmental and Occupational Health Sciences. Dr. Cherry is an expert in injuries and illnesses that result from exposure in the workplace. She takes pride in promoting the health and safety of workers and assisting injured workers in their transition back to work and managing workers' comp claims efficiently. Dr. Cherry earned her MD from Texas Tech, Lubbock, and her MS from Stephen F. Austin University in Nacogdoches, Texas. She is a member of the American College of Occupational and Environmental Medicine. Her clinical and research interests include work-related injury and illness, exposure to hazardous waste products, pediatric environmental health, work hazards associated with commercial fishing, and resident education. And with that, I hand this over to Dr. Cherry.
Thank you. Thank you for that nice introduction, Eric. It's a pleasure to be with you all this morning to talk about lead exposure, which is one of my favorite topics. I'm getting a little bit of an echo. Okay. Oh, I think that's better. I don't hear it now. Okay, very nice. So yeah, I'm more in the world of adult workers now in occupational medicine, but I spent the first 10 years of my career really focused on pediatric environmental health. In fact, I did my intern year in pediatrics at Children's Mercy Hospital in Kansas City, and I was an investigator in the National Children's Study for about 5 years, which looked at the impact of the environment on children's health and development. There we go. Okay. So, funding for this talk is from CDC through a cooperative agreement with the Oregon Health Authority. And the Oregon Health Authority contracted with the Pediatric Environmental Health Specialty Unit in Seattle. That unit is funded by a joint agreement with EPA and ATSDR, and I'm affiliated with the Seattle PACU, is how I got involved in this series of talks about lead poisoning in Washington and Oregon. But the opinions I express today just reflect my own personal opinions and not those of the funders. And as mentioned earlier, I have no conflicts of interest to disclose. The reason CDC has funded this series of local and regional talks about lead poisoning is that lead is really a local problem with local solutions. Every area of the country, state, and really down to the local neighborhood level has unique issues related to lead poisoning, sources of lead poisoning, and different testing and surveillance and reporting requirements by state, certainly. So it's a pleasure to be giving you this talk and lead is one of the classic environmental exposures that we want to try to avoid and eliminate if we can. But we'll talk about sources of lead exposure, particularly in Oregon, and health effects of lead. That's a little more universal. It doesn't really matter where you live. Lead can have impacts on health and development of children. Then we'll talk about testing and follow-up, particularly the guidelines for Oregon, and then some anticipatory guidance pertaining to lead screening, diagnosis, management, and prevention. Okay, so what do you think accounts for the majority of childhood lead exposure? Do you think it's automotive repair, drinking water, lead-based paint, lead glazed pottery, contaminated soil, or cultural products like coal or surma, as pictured in the lower right corner here? Those are products that can contain lead. But what do you think is most common in Oregon? I guess I'll make that a bit of a rhetorical question as you're all muted, but if you said paint, you're right on. So even though all those are potential sources of lead in Oregon, if we look at probable sources for childhood lead exposure, meaning elevated blood lead over 5 in Oregon, from 2014 to 2020, far and away the most common source is lead-based paint, which can, chip off, and when it deteriorates, it can get into house dust. Other sources, though, in Oregon include country of origin, some imported products, or cultural practices that use lead-containing products can cause lead exposure. You can have traditional or homeopathic or cosmetic products with lead. Antiques, toys, jewelries, or bathtubs can have lead, and in some children who are exposed, multiple sources are likely. There was an alert recently in Oregon because the spice turmeric was contaminated with lead, at least, some of the imported product. Not all turmeric, just some was contaminated with lead. Lead can be added to different products because it increases the weight. So for products like spices or actually some of the illicit drugs that are sold, sometimes lead is added to increase the weight of the product since it's sold by the ounce. You'll notice that drinking water is not listed here, even though sometimes drinking water gets a lot of press. There was the Flint, Michigan episode with all the elevated lead in drinking water. But usually drinking water is not correlated with elevated blood lead. So we don't want to see lead in drinking water. It's not ideal, but it's not really known to be a source of blood lead poisoning, at least in the United States. And if you're like me, you've had a couple of cases here and there where you never can find the source, and that gets frustrating. And maybe that's overrepresented in, like in my mind, because those are the most frustrating cases. But Brian from the Oregon Health Authority let me know that at least in about 87% of investigations, the health authority could identify at least one probable source of lead exposure. And about 2.5% of children screened nationally, or about 1 in 50, have lead over 5. And I know that some of the registrants in our sort of pre-talk questionnaire said they'd never seen elevated blood lead. That's not super surprising. You'd have to screen on average 50 or 100 kids to see 1 or 2 elevated blood leads over 5, but it's still worth doing. There we go. So if we look at sources of lead in Oregon, the risk factors for elevated blood lead include poverty, large number of children under 6, foreign-born populations, and housing age, where homes built before 1978 are at higher risk of having lead-based paint. We find that No, a lot of the more urban, densely populated areas have the highest risk, but rural areas it can also be at risk, because we'll talk about some sources here in a minute where it had nothing to do with the geographic location of the home, but certainly some of these areas of Oregon have higher risk than others. You know, those areas in orange and pink here have the highest known risk factors for lead exposure. And if we look more closely at some of these regional maps, the areas around Portland, Salem, and Eugene Springfield have some of the highest risk areas. I know we had one participant from Silverton, which is one of the higher risk areas. But geographic risk factors aside, now I want to talk to you about a few things that have occurred in Oregon that, you know, you'd never predict from the geographic location. You know, in 2019, there was a 12-month-old child in Oregon who had elevated lead on routine screening. And in the home interview by the Oregon Health Authority, the parents said the child had Impacto, which is kind of like colic, and then prescribed this medicine, a bright orange-red powder that's virtually pure lead, 93% lead. This is called Azarcon or Greta, and it's kind of a cultural remedy for colic or Impacto in some Latin American communities in particular. Contaminated soil can be a source of lead exposure. In Portland a few years ago, Multnomah Metals was a lead smelter that had inadvertently contaminated the surrounding soil with lead, and then some residential homes were built on the contaminated soil, and the EPA had to come out and replace a lot of lead contaminated soil and in about 5 yards of 5 homes. And that's been resolved since then, but something like that can occur. You can also have sort of one-off contamination of the soil. There was a Portland family who had a 12-month-old with a screening lead level of 13. And when the source was investigated, they found that the previous homeowner had collected junk cars in the yard, which had leached lead into the soil. And the soil was about 12% lead in this home, so EPA had to come out and remove over 400 tons of soil from the property and replace it with uncontaminated soil. You can also have toys containing lead, unfortunately. There was a Portland case in 2003 where a 4-year-old boy presented with severe symptoms of lead poisoning, abdominal pain, constipation. He couldn't eat or drink, and he bit the inside of his cheek, probably due to a seizure. And it took a long time to figure out what was going on with this child, but they finally checked the blood lead, and it was 123 micrograms per deciliter, which is much higher than most of us will ever see in practice. And it turned out 3 weeks earlier, he had swallowed a lead medallion that came from an Oregon vending machine. And this case was written up in MMWR. So some questions I've received from Oregon healthcare providers about sources of lead include, like, do health departments have the resources to do home investigations for blood lead? And I know in rural areas it can be challenging, but it's preferred that the local health authority do the investigation. But if they don't have the resources, certainly the state will come in and do a home investigation. You can contact Ryan Barker, he's on the call today. He's the coordinator for the lead program in Oregon, and he will have some resources from the state to do that home investigation. How does a family get their home tap water tested for lead? Well, you can contact the Oregon Environmental Lab Accreditation Program, and they will provide a free test kit, but then the analysis costs $30 to $40 to see if there's lead in the tap water. Then I've been asked, are Oregon children getting lead poisoning from tap water in schools? Again, like I said earlier, elevated lead in drinking water has not been correlated with elevated blood lead, but nonetheless, we don't want lead in drinking water, even if it's a tiny amount. You know, it's better not to have it at all than to have it above the EPA limit. So Oregon has required all schools to test for lead in drinking water, and they're trying to eliminate any sources of lead in the plumbing. Okay, so that concludes the sources section. See, it's 8:17. I'm just gonna go ahead and we'll do Q&A at the end. So now we're going to talk about health effects. What are the health effects of blood lead levels in the 5 to 10 range in children under 2 years of age? Do you think it's ADHD at age 10, loss of 5 IQ points by about age 10, criminal behavior by age 20, reduced hearing later in life, or anemia? Well, this one may surprise you. It surprised me because when I was in medical school, I learned that one of the primary health effects of lead exposure was anemia. But actually, we don't really see that until the level gets up into the 40 to 50 range. So A through D are actually correct. And E, you really don't see at the lower level of lead, which is 5 to 10 range. Again, anemia you wouldn't see until the level gets to 40 to 50. But these latent or long-term effects of early lead exposure are really important. The National Toxicology Program recently reviewed the level of evidence for long-term effects of lead exposure and found sufficient evidence, which is the highest level of evidence they assign for long-term neurological effects, including attention problems, antisocial behavior, criminal behavior, reduced cognition, effects on growth, and reproductive effects. And about 20 years ago, a study found that IQ declines 7 points as blood lead increases from 1 to 10 micrograms per liter, and then has less of effect on IQ at levels above 10. And this looked at the lifetime average blood lead concentration, and then the IQ kind of at school entry. So again, it's a latent effect, but certainly substantial. And then a 2018 study found that ADHD risk doubles in boys as lead in childhood increases from below 5 to between 5 and 10. Again, this is the lead level at 1 year of age versus ADHD at 10 years of age. So it's a latent effect, but we really want to eliminate that early lead exposure, even at low levels. And you might not be able to tell a difference of 5 IQ points between two children, but the impact of loss of 5 IQ points on the population is substantial. If you look at IQ as a bell-shaped curve, and without lead exposure, if we have 6 million challenged and 6 million gifted children, then if the whole population of children had a low-level lead exposure between age, birth and 3, we could shift the whole bell curve to the left, resulting in, instead of 6 million, 9.5 million challenged children, and instead of 6 million gifted, only 2.4 million gifted children. So having lead in the environment has a big impact on the population. Just some questions regarding health effects of lead that I've received from different audiences. What are the most common signs of lead exposure? Well, for most of us, we're not going to see any signs with the low levels. I mean, for blood lead under 40, there are no or minimal signs at the time of exposure, but there's great concern for developmental effects that show up later in life. And what should I tell the parent of a child whose blood lead is 4 regarding the impact on IQ? Not to panic. You want to recheck the test because the precision of the test is plus or minus 2, so 4 might mean 2 or 6. And individual impacts on IQ are really complicated because there are so many complex factors that impact IQ. It's hard to isolate the impact of a single factor. And things like parental IQ and having a household with an enriched learning environment with lots of books, etc., have a big impact on IQ as well. So it's impossible to say how a single elevated lead is going to impact an individual child, but we know from population studies that on average, there's a 1 IQ point loss for every 1 microgram per deciliter increase in lead, especially at low levels. Okay, so that's the health effects section. Now we'll talk about lead testing and follow-up. So what's the purpose of childhood blood lead screening? Do you think it's to reverse the effects of lead exposure, to comply with Medicaid guidelines, to identify asymptomatic lead poisoned children, or to intervene as quickly as possible to reduce blood lead levels? You know, it's actually B, C, and D are correct. You cannot reverse the effects of lead exposure after exposure has occurred. You know, that may be why the U.S. Preventive Services Task Force has given childhood lead screening, you know, an I recommendation instead of an A, because, you know, it's really to prevent future exposure, to comply with guidelines, and, you know, eliminate lead sources from the environment is certainly part of it. But after the exposure's occurred, you really can't reverse the effects of lead exposure. If we look at lead and lead testing and follow-up in different states around the country, we find that Oregon and Washington as well have very low rates of testing. This graph shows expected versus reported lead cases state by state. In Oregon, only captures about 8% of the expected number of elevated blood lead cases due to lack of screening. Elevated blood lead does occur in Oregon. Again, I know one of our registrants said she'd never seen elevated blood lead, but actually if we look at cases of elevated blood lead from 2010 to 2018, you know, we're seeing 100 or more cases a year that are over 5 across the state, and that's with the kind of the lower testing rates that we have now. And about 213 in this time span had confirmed blood lead levels over 10. There we go. We asked the registrants for this talk, what are you doing now for childhood lead screening? And we got a pretty big variety of replies, even in this small audience. Who do you screen? Some folks said they use targeted screening. They use the lead questionnaire and just identify folks who say yes or I don't know to the risk factors. Or they just ask about housing age and maybe screen those who live in older housing. Or blood test all Medicaid children, which is actually the right answer. And we asked, you know, when do you screen? Some folks it was 1 and 2 years. Some said 1 and 4 years. Some said just before starting Head Start. I'll give you a hint. It's supposed to be 1 and 2 years, which we'll talk about more in a minute. Oh, I see you can't hear me. I see.
I can hear you, Dr. Sherry. Who are you getting that from?
Oh, I saw a pop-up that said I can't hear you anymore. Okay. Okay, good. I think we're okay then. All right. So again, some of the screening practices were kind of all over the place. So let me tell you what you're supposed to be doing. And some people are doing the right thing apparently. Again, not a scientific sample, just a few responses is what we got from this audience. But Oregon State screening protocols are to screen all Medicaid patients at ages 12 months and 24 months, or between 3 and 5 if they've never been screened. So, you know, it's not wrong to screen right before they go into Head Start if they've never been screened before, but they should have received a test at 1 and 2 years of age. For Medicaid patients, it's not supposed to be just the screening questionnaire. And then all patients who are not on Medicaid or OHP, they can be screened with the questionnaire at the same ages as above at 1 and 2 years. Or the blood test is acceptable as well if you just want to do the same screening test for everyone. And then waivers for blood lead tests are not accepted. There was a statewide survey of Oregon healthcare providers that included pediatricians and family medicine providers. Excuse me, I've got the sun's coming up and my lighting's a little wonky here. Anyway, challenges of video conferencing. We asked or the Oregon Health Authority asked if providers were aware of the questionnaire. Only about half were even aware of the lead screening questionnaire. We asked if they use a different method for screening Medicaid compared with non-Medicaid, and most use the same for all patients. Either everyone gets a blood test or everyone gets a questionnaire. You know, I would favor everyone gets a blood test. And only a few blood screen Medicaid and questionnaire screen non-Medicaid patients, which is the law. You're supposed to blood screen Medicaid patients and questionnaire screen non-Medicaid patients, then follow up with a blood test for any positive responses or I don't know on the questionnaire. So we ask, are you aware that CMS requires all Medicaid children to be screened with a blood test rather than a questionnaire? And most were not aware of that. And here's just a picture of the questionnaire. I know most of you are aware of it. Again, you can use this on your private insurance patients. Ask the questionnaire first, which asks about risk factors, older housing or cultural factors. And then if they have yes or don't know, you're supposed to follow up with a blood test for private insurance patients. Okay, so how do you collect the sample? Again, venipuncture is the most accurate, but it can be hard to access. You can first start with a capillary test, which can be a finger stick or a heel stick. That's the point of care testing. A lot of capillary tests are done. The sensitivity and specificity of the capillary test is really good. To reduce false positives from contamination, there's a few things you can do. Shake the hands dry, don't use paper towels. Take the lead sample first before other blood samples, and take the second drop of blood as a sample just in case there's any skin contamination in the first drop. And then if the lead is positive, you're supposed to confirm with venipuncture. We had some questions about oral fluid screening. I know one of the registrants reported that some folks are getting an oral test for lead poisoning, particularly some dentists in the area, and there was a reference to this article from 2016. And the test was not so great. I mean, in this article, they tested 407 children who met with concurrent blood and saliva tests. There were 223 true negatives, 176 false positives, 8 true positives, and 0 false negatives. But the conclusion of that article was the test needs further study, and that was published in 2016. And I didn't see many other studies of this oral test following that. The oral test is not acceptable to CDC or Oregon Health Authority. It's not reportable. We couldn't compare the results of a saliva test to any other tests in the literature or state or national blood levels. And OHA will not record or investigate oral lead tests. So you're really discouraged from doing this oral test. As I mentioned earlier, if you have a positive capillary test, you're supposed to do a venous follow-up within 1 to 2 weeks. You know, you can wait 3 months for a follow-up venous test after a positive capillary test, but do the confirmatory test, because otherwise no one knows if that capillary test was a false positive or a true positive. So do try to get the venous testing as soon as possible, or within 7 to 14 days after a positive capillary test. Most of us are not going to see blood leads above 20. Maybe if you do see a higher blood lead, I would just encourage you to look up what the follow-up testing protocol is, because it's hard to remember all the follow-up for each level. But if you can remember, if it's below 20 but positive, get that confirmatory test, you know, within a week, and then a follow-up venous test in 3 months. Organ lead reporting, the labs are actually required to report any blood lead over 5 within 1 business day. But if a clinic does point of care testing with a capillary test for blood lead, then the clinic has to report positives and negatives directly to the Organ Health Authority. Can't rely on the lab to do it if you're doing the capillary test in your clinic. And the Organ Health Authority refers all the elevated blood leads to the local public health authority to investigate. Or if the local health authority is notified first, they notify the state. And there's a link here where you can find the reporting forms for the lead poisoning prevention program. So just to be sure to report all your capillary tests to the state. For newly arrived refugees, the lead screening is a little more aggressive. I don't know how many of you see refugees in your practice, but even up to 6 years of age, they're supposed to get an initial blood lead and then a follow-up within 3 to 6 months after resettlement. And then you get that initial blood lead even in children as old as 16 years of age. Young children are supposed to get CBC with dip and be provided vitamins and iron after they arrive in the U.S. Okay, that's the section on testing and follow-up. Now we're going to go to some anticipatory guidance. We'll just talk for a few minutes about this, and then we'll have some time for Q&A. So we want to avoid lead exposure from happening in the first place, if at all possible. Again, paint is far and away the most common source of lead poisoning, both in Oregon and around the country. So to avoid lead in paint, you know, keep your child away from peeling paint and home repairs that may disturb lead-containing paint. If you're renting and you have concerns about lead exposure or renovations, you can contact the Oregon Health Authority to discuss your concerns. You need to frequently wash hands, toys, pacifiers, and bottles and other items that the child places in the mouth. Clean floors, windowsills, and dusty places with wet disposable cleaning cloths. We used to say wet mop, but then if you get lead dust on the wet mop, you can just spread it around the house. So it's better to use disposable cleaning cloths. And vacuum with a sealed HEPA filter. So if you're vacuuming up, you know, lead contaminated dust, it's not just blowing out the back of the vacuum cleaner. And use safe methods when doing home repair that disturbs paint. And EPA has some pretty detailed protocols for doing home renovations where you might be disturbing lead-based paint. Again, there are some sources beyond paint. Some things you can tell families include avoid using health remedies like Azarcon or Greta, that orange lead-containing powder we saw earlier. Avoid some of the eye cosmetics like kohl and surma that are sometimes applied around the eyes or on the face of young children. Some of those can have high lead levels. Use caution with any kind of imported products, candles, spices. Again, lead has been found in turmeric in Oregon. Snack foods, children's toys, or jewelry made in other countries, which can have lead. Keep your children away from clothes and tools that may have lead contamination, and wash work clothes separately from the home laundry. Our PASU has some fact sheets on traditional sources of lead that you can download and give to your patients. Things like glazed pottery, imported cosmetics, and jewelry. And you can see there's some other things here for South Asian populations in particular. Some of the, again, the kohl and surma and other products that may contain lead. And then a lot of people are concerned about lead in drinking water. I wouldn't go crazy about the drinking water if I were you, but you know, there are some things you can do if you're worried about lead contamination of drinking water. Like if you live in older housing, run the tap for over 2 minutes after the water has set in the pipe overnight. You know, if you live in newer housing even, you can flush your pipes by running tap water until the water's cooler. That will help reduce any lead that's present. Use cold water for drinking, cooking, and baby formula, because if there's lead in the pipes, the hot water will tend to leach the lead out of the pipes a little bit more. Clean the screens and aerators of faucets, use lead-free pipes, and consider a filter. But you want to make sure that the filter you're using reduces lead. You can look at the NSF for performance standards to see if it is a filter that actually removes lead from the water. And then we want to promote healthy neurocognitive development, whether the child's exposed to lead or not. A lot of things can be done to improve cognition in children and you know, enhance behavioral development. These include good nutrition, educational enrichment, getting plenty of physical activity, limited screen time, having a safe environment, and getting plenty of sleep. If you do have a child with elevated blood lead over 5, they automatically qualify for this great Oregon program, Early Intervention, Early Childhood Special Education. So any child with a blood lead over 5 can qualify. You just have to make the referral, and they can get some special help for their learning. Here's some, and that's the end of the talk, but here's some resources for you to be aware of. Our PASU, the Pediatric Environmental Health Specialty Unit, has some information about lead exposure. Again, the Oregon Health Authority, I think I sent their website around, or I brought it to the attention of our talk organizers today. It has some great information about lead exposure and prevention and reporting, particularly in Oregon. AAP has some great information about lead poisoning, and EPA about lead sources. And then here's some references that I used in the talk. You're welcome to read in more detail. Okay, that's it. I'm going to try.
Yeah, I can read those questions for you, Dr. Cherry, if that's easier.
Yeah, do you want to stop share so I can see more of the participants? Or we can stop screen. I don't know if I'm not sharing, so I think it was Ryan. I mean, Eric was sharing. Yeah.
I'm not sure if participants will be visible. You can see a participant list, and some folks have sent things with their own names.
Okay.
So from
let's just go
Sandy,
ahead with the questions.
Great. Sandy Waters says, if you were surprised with the effects of lead in children, then most people are not aware of it. What is the plan to get this information out nationally?
Well, there's been quite a lot of publicity about it. That's interesting that people are not aware. You know, this is something I talk to my own children about quite a bit because lead poisoning has been described since, you know, at least since the Roman Empire, you know, and Ben Franklin talked about lead poisoning. They had lead poisoning in the colonies. So I don't know what can be done to get the word out because, you know, the word's been out for a long time. Maybe people are not paying attention. I don't know what to say about that. You know, CDC has a lot of information about lead. I think it's lead poisoning has been around for so long, maybe people get numb to it.
Okay. Interestingly, I was really struck by the fact that Medicaid requires it, whereas private insurance doesn't, and that seems to be a reflection of the likelihood of harm. And we have a participant, Rebecca, who says, I'm concerned at having a different standard of an intervention based only on insurance/income. It seems to be unethical to submit kids to painful procedures based only on their insurance if they live in low risk areas and have no other risk factors. So could you address that?
Yeah, because I would think the opposite, that everyone on private insurance needs the blood test, not just Medicaid children. So, yeah, and you know, I guess the reasoning is Medicaid children tend to live in, have a higher risk of living in housing with lead contaminated paint, but that's not always the true. I mean, you can have certainly folks with private insurance living in older housing. So I think the right answer is just to blood test everyone. And I agree, there shouldn't be a different standard for Medicaid and private insurance. That doesn't make any sense to me.
Yeah.
But in terms of the blood test, they should both get, I think, both get the blood test because you can always have these one-off cases like the cultural products or the, you know, turmeric. In fact, you know, one in my experience, we had a really well-to-do family from India that their child got lead poisoning from using the coal as a cosmetic product on their child.
Oh my. Yeah. Thinking
Hey,
about
this
that
is
map of Oregon with the high rates, does it make more sense to focus particularly on those areas?
Yeah, I guess. I mean, I kind of think, again, everyone, whether they're rural or urban, probably needs a lead test at age 1 and 2. That's my opinion. But you'll get a little bit higher. Maybe you'll get, I don't really know what the results are. Maybe you'll find 1 in 50 have elevated lead in those high risk areas, and maybe 1 in 80 in the rural areas, but I don't really know.
Hey, this is Ryan from OHA. Can you hear me?
Yes.
So we've actually done some internal kind of validation of the map that Dr. Cherry showed with the high risk tracks, and we've actually updated it again this year with new census data, and we see higher percentages of children with elevated blood lead levels within those census tracts. And so it does have a pretty good predictive value, and we're looking at potentially in the future using that those high-risk census tracts as kind of an additional screening tool. So along with the federal Medicaid requirements, so kids on Medicaid, the Oregon Health Plan, required to be tested at 1 and 2 or between 3 and 5. That's a federal requirement that all states have to abide by. We're also looking at potentially doing more of the high-risk census tracts as an additional screening tool. But as of right now, it's just the OHP Medicaid requirement and then the questionnaire for all children on private insurance.
Sounds great. I know we're at the end of our time. We have one more question from a real attendee versus me. Why do you think Oregon and Washington have such low rates of lead screening?
I don't know. Ryan, do you have an opinion?
I think it's just several different factors of, just talking kind of one-off with different medical providers. I think there's the perception that in the Pacific Northwest, there's not as high of a concentration of older housing. And so, some providers don't think that lead poisoning is an issue here, which, I've talked to like one provider from San Francisco who talks about the difference of how many kids he saw there as opposed to here, which is totally understandable. But we also have other factors that maybe other parts of the country don't have. And we've seen exposures related to occupations that are unique to the Pacific Northwest, you know, cultural communities that are maybe, you know, different here than in other parts of the country. So, you know, as Dr. Sherry showed, you know, that one study showed that we are only identifying about 8% of the kids were expected to have lead poisoning. But I think with additional outreach and education about, you know, the potential health effects of lead poisoning, you know, we hope to see more kids get tested along with the Medicaid requirement and that kind of thing. Just making sure that kids get tested if they're supposed to be, and so we can identify those kids with elevated blood levels and help them, you know, get the resources and services that they need. So I think it's a lot of perception. Again, you know, Pacific Northwest doesn't have as much of a problem as other parts of the country, which might be true, but that doesn't mean that we don't also still have kids with, you know, elevated blood levels that need our assistance.
I think that's it for questions from our attendees. Dr. Cherry, any closing words? And Eric, do you want to take us out?
I just saw the pop-up, is OHA willing to pay for point of care testing? I'll let Ryan answer that, but I doubt it, but let's.
So that's a great question. We actually have a couple that we've loaned that we can, you know, if you want to use one for a while or try it out and see what it's like, we can definitely loan one. The facility would be responsible for purchasing the test kits, which aren't as expensive as the analyzer. But our program is funded solely by the CDC, and that's one of the stipulations in our funding is we cannot purchase materials such as lead care testing analyzers and things like that. So unless we had some additional source of funding that we don't have currently, we wouldn't be able to do that, unfortunately.
Thanks, Ryan. And thank you, Dr. Cherry, for this fantastic presentation. Everybody, I've put the survey link into the chat. We'll be emailing it to you as well. The slides and the recording from this session will be up on our website within the next day or so. It just takes time for the video to be rendered by WebEx, and then we'll post it. I hope y'all have a great day, and we'll see y'all for the next session. Take care, everybody.
Thank you.
Thank you.
Bye-bye.
Pleasure
Bye,
being
everybody.
with you this morning. Bye.